Rafat, glad to welcome you from your center in Indiana University, Indianapolis, and you're going to take the confusion out of what to do next. So go ahead, Rafat.
Well, yeah, good morning. Thank you, Brian, for inviting me to participate in this meeting. I wish we were in Boca Raton, but here we are.
Yeah.
And Paul did an excellent job, really, tell us about immunotherapy and the excitement of that. So my job is to sort of talk about, how do we approach relapse disease? Okay, I'm going to ask the audience, maybe they can put in the chat their response. What do you call the second COVID vaccine? And I'll come back to it at the end of the talk. So when should we treat patients, with relapse disease? Do we treat them when we have a biochemical relapse? That means the myeloma proteins start going up, the free light chain that is involved going up, or when they have a clinical relapse, the CRAB criteria, anemia, kidney failure, high calcium, or new bone disease? Do we treat them when they have extramedullary disease, like the patient Paul just showed you with a mass in the liver, or if they have plasma cell leukemia? The answer is we really don't know yet. We can speculate. But I just want to bring to your attention that most approved treatment today in relapse multiple myeloma were based on biochemical relapse, not symptomatic relapse. But there are two observations support better outcome when you treat at biochemical relapse. One from Mayo Clinic, when they looked at the patient treated at biochemical relapse versus symptomatic relapse, and there was a significant difference in median overall survival, 125 months versus 81 months. There was another trial called the Endeavor trial, showed similar results. So what are the cons and pros of treating at biochemical relapse? Well, about 25% of biochemical relapse, when just the myeloma protein is going up, may actually have a smoldering course with no progression for over 2 years. So maybe these people get overtreated. The pros is that some observations showed that median time between biochemical relapse and clinical symptoms, maybe it's about 6 months. So why wait until you have a broken bone, renal failure to treat the patient? Similarly, what we're doing with smoldering disease, but it's a little different. And the other pros is that if you really don't get it right at the first relapse, you may not get it right at subsequent relapses. Why is that? If you look at the duration of response with each relapse, for example, with first relapse, the duration of response could be about 10 months. With second relapse is shorter, third relapse is shorter. So with each relapse, the duration and the depth of response is shorter. So I think we need to get it right at the first relapse. I think it's very important. And you heard from Paul about the genomic heterogeneity that's affecting the course of multiple myeloma. So because multiple myeloma patients have distinct subclones, smaller population of plasma cells that are sort of causing intramural heterogeneity, affect the course of the disease, and affect the outcome with each relapse. So to say that in English, what is clonal heterogeneity is that myeloma cells in each patient are a family of odds and aggressive members. The longer this family stick around, the odder and more aggressive it becomes. So family therapy is not going to work. You cannot be politically correct here. You have to eradicate them quickly. This is making a case for early treatment with combination therapy, as you heard from Paul and others. We're not going to win with single agent drug or two drugs. We need combination therapy to address the clonal heterogeneity and prevent these cells from becoming aggressive and then causing relapse with extramedullary disease, plasma cell leukemia, and the like. So what are the factors that influence the choice of therapy at relapse? They are disease-related, regimen-related, patient-related. So what are the disease-related factors? What is the clinical feature associated with relapse? Symptomatic disease, extramedullary disease was hyperviscosity, came from high-risk cytogenetic, you have extramedullary disease or high-risk myeloma. That will influence your combinations and how you do decide on the appropriate treatment. The regimen-related factor, what was the previous treatment and the doses the patient received, the duration of prior response is very important. The side effect of prior treatments, prior drugs and combination is very important. You're not going to repeat drug that caused significant nerve damage or cause significant allergic reactions or the like. And the depth of and duration of prior treatment or previous transplant also can influence what we do. Do we do a second salvage transplant 5 years later? Maybe. And obviously, we need to respect the patient's related factors, how they feel, what's their performance status, do they have any other medical issues, are they eligible for transplant or not, what does the patient want? And, obviously, sometimes we have to address cost and socioeconomics. So this is a list of currently available anti-myeloma agents. As you can see, there are a lot. Obviously, we still have the prednisone and the dexamethasone. We have these conventional chemotherapy with novel twists on them, such as the newly approved melphalan. We have the IMiDs, thalidomide, lenalidomide, pomalidomide, the Revlimid, Panelists. We have the 3-proteasome inhibitor. We have the HDAC inhibitor. We have these immunologic-based approach, and then we have the EXPO inhibitor, selinexor. So how do we choose, Basically, how does your oncologist decide? It's like you're going to this restaurant with this incredible menu, It's just very difficult. I mean, which salad, which, main I want to choose from? Well, it's actually, this is what your oncologist is seeing. I mean, every oncologist is following what we call the NCCN guideline, the National Cancer Center Network guidelines. And look at these regimens. It's great that we have options. Look how many options available for relapse patients. But the bad news is that your doctor may get confused. Which one I'm going to pick from these combinations? Well, I mean, you could probably use your Mayo practical approach to first relapse. For example, if they were on maintenance Revlimid and they relapse and they fit, you can, for example, use carfilzomib, pomalidomide, and dexamethasone, or DARA-VD. So this is an attempt, by our colleagues at Mayo Clinic to sort of make it easier for the oncologist compared to the NCCN guideline. If you have somebody who, for example, relapsed and was refractory to lenalidomide, you will probably use something different. So these are available, and I'm not going to spend a lot of time on it. Obviously, if somebody has a very aggressive relapse, so is extramedullary disease, if there's no clinical trial available to them, we may be very aggressive, use this combination chemotherapy in the hospital for 4 days, a month, for 2 months, and then maintain him after that. So, so let's spend, a few minutes talking about some of these combinations. So you heard again, it's really not good idea when somebody relapses to just use a single agent drugs, because single agent drugs, most of the, they're going to give you a 33% response rate. So, and these, for example, drugs, when approved in combinations with based on clinical trial, showing that 3 drugs are better than 2 drugs. For example, in this trial, in the old days when somebody relapsed, we're going to give them Revlimid Dex. How about adding a monoclonal antibody to daratumumab, anti-CD38? And what you can see here is that in this trial, the time without relapse is much longer with 3 drugs, and the median not reach. However, when you just use Revlimid Dex, patients start relapsing or having symptoms related to the disease within 17.5 months. So clearly, 58% is better than 35%. So 3 drugs better than 2 drugs. Combination therapy is very important. And, the response is deeper. You're getting more patient getting complete remission, stringent complete remission. And that is translating to a better survival. Patients stay alive and staying without disease much longer. And the other thing is that combination therapy is leading to a deeper level of response. You're getting more patients achieving minimal residual disease with the 3-drug regimen, as you can see here, based on different sensitivity of the assay. But clearly, in a very sensitive assay of, let's say, 1 in 100,000 cells, you're not finding a single myeloma. There are 27% of the patient achieving that versus with Revlimid Dex is only 5%. So clearly, the quality of the response is much better when you get a minimal residual disease. And patients who get minimal residual disease enjoy a much longer survival without symptoms related to the disease. And in this analysis, basically, time from last line of therapy to study treatment, again, if patient got a late relapse or early relapse, combination therapy is superior. And so, again, makes the case that when you have a relapse, you need to use combination therapy. The Castor study is similar to this study, but it was comparing daratumumab with bortezomib dexamethasone to salvage with bortezomib dexamethasone. And similar observation was noted here, and the depth of response, the quality of response were similar. And again, whether you're using it for early relapse or late relapse, still there's benefit to combination therapy over just the doublet. So these two studies are seminal studies showing that combination therapy is very important at relapse, and overall survival is in favor of combination therapy. So the other really advanced in myeloma therapy came last year when the FDA approved drug bilinen, mafodotin. And this is really an exciting advances. So this is, you heard about the importance of BCMA as a target for immunotherapy. Everybody is using BCMA, whether it's a CAR T cells, bispecific. But the only approved anti-BCMA drug right now is this drug. And it works in two ways. It's an antibody, so bind to the myeloma cells and then bring the immune system and help eradicate the myeloma cells, but also has a conjugate added to it. And this conjugate, it's a tubulin sort of inhibitor, we call it. And basically, it goes inside the cells, this cytotoxic agents, and then blow up the cells. So it has dual mechanism of action. One is bringing the immune system to try to eradicate the myeloma cells, and then getting this cytotoxic agent, MMAF, within the cells to help eradicate the myeloma. So what happened, I think this is just one of the many trials have been presented with this drug. And this is the sort of phase 1 study showing that there are a lot of patients had a response with an overall response rate initially of 60%. So what you heard from Paul is that we are building on this agents because, again, all drugs have to be first approved as a single agent to show activity. And then the next thing is that you use it in combination. So there are a lot of combination using this drug, ongoing in clinical trials showing efficacy. And I think eventually this drug will be approved in combination and probably different dose schedule. So you heard about the major issue related to this drug is really the ocular toxicity. And the mechanism why patients are getting eye symptoms related to this drug is not very clear. But mostly is corneal, the cornea damage related to this treatment. And so it's very important that this drug is not giving until you have a good eye exam. And prior to each cycles, you should be having an eye exam. And I think, nowadays, I think we've been able to find ophthalmologists and optometrists in our network that can really provide us the exam quickly and provide us the results. Because you heard earlier in the morning that you need to know if the patient is a go or not in terms of getting the treatment or not, because if there's significant toxicity, you need to hold the drug until the symptoms resolve, and then you can restart it. And it's one of the things that the patient can do is to use non-preservative eye drops, like artificial tears without preservative frequently to keep the cornea moist and prevent it from getting ulceration. The other recently approved drug, and Paul can probably provide you with more data on that since he was the PI on this study, is really this new drugs, melphalan, in patients who have been relapsed to many line of therapy, including daratumumab and pomalidomide. So what is this drug? It's an interesting drug that has several mechanisms of actions. I'm not going to go through them, but it really, it's an easy sort of modified alkylating agents that can be given once every 4 weeks and lead to significant myeloma destruction. And in this study, the primary endpoint was obviously overall response rate for single agent drugs. And these are the patients, you can see that in your handout. But all I want to tell you is that there's significant response with single agent activity. And some of these responses were quite deep, complete remission and stringent complete remission. So again, it's a new drug that is available to us to help us, compact multiple myeloma. Because of time restraint, I haven't been able to go over the list of all the medications I showed you earlier. But I think, the best therapy for relapse, that we need to know that not all relapses are the same. So, and the good news is that we have options that will suit each patient we treat. We know that combination therapy provide better outcomes, so we should be adopting that to all of our patients. And, we have amazing, options today, which is really, great. 20 years ago, we had, 1 or 2 drugs. Now we have many drugs and many combinations. So really the optimal therapy is the one based on your needs. And I really cannot underscore the need to get it right at first relapse, because if we don't, the disease become more aggressive and very hard to control. With that, I am done. Thank you.
Okay, well, there you go. There's a poster for relapse and myeloma. So thank you so much, Rafat, for that excellent overview of how to approach relapse, and then some of the more important newer agents for treatment and relapse.